Hursler's socket shield technique, first published in 2010, is no doubt one of the most controversial topics on our actuality. Yet, there were two publications that for me were convincing enough to make me start trying this technique. The first one was Ballmer's histological and volumetric observations in dogs, which revealed that the tooth segments showed healthy periodontal ligament on the buccal side, that new bone was visible between the implant surface and the shield, also didn't show osteoclastic remodeling of the coronal part of the buccal plate, and the volumetric analysis showed us a mean loss of 0.88 millimeters in labial direction. The second one was Schwartz's proof of concept studies results, which were very interesting by showing that autologous natural roots could be used as a biomaterial for bone growth regeneration. So I guess that the next time we accidentally hit a neighbor root when placing an implant, we can be a bit less worried. But there's no doubt that our biggest challenge is to maintain anatomy. So we remembered to try adding a biomodulator agent to this technique, the endoret graft, like we normally do on immediate post-extraction implants. We also did some changes to the original technique to try to prevent soft tissues from growing in between the abutment and the root fragment, as shown in Ballmer's histological results. So we reduce the root shield to the bone level because we want the bone to directly contact our abutments. And then we're going to place the implant around 1 millimeter below the bone and root level. Next, we want to show you a case where we performed a PET technique, although not yet with the PET kit presented by the team Atlanta, on the upper left side. As you can see, the patient showed a decay on the premolar, so we planned an immediate post-extraction implant. At the CT scan, while going through the cuts, we can see that there was a need also to perform a transcrestal sinus augmentation. Let us check the surgery. So this was the decayed bridge that we removed. The first step was carefully remove all the decayed root structure, and then we separate both halves of the root with a thin burr, and after it we gradually start reducing the palatal portion until it gets thin and it can be easily removed. It's very important not to leave any loose root fragment, so that's why we had to remove that one. After preparing the shield, we used a couple of burrs to prepare the implant site, and then, as we were able to see at the CT scan, we did a transcrestal sinus augmentation using xenograft bio-activated by the endoret following Summers' technique. After making that little sinus augmentation, you're going to biomodulate the socket with endoret and then insert the implant. It's very important to check where the bone level is in order for us to adequate the correct implant depth. Of course, we control our implant position with a very simple but accurate surgical guide. And then we protect our connection with a healing abutment and fill the gap with this xenograft bio-activated with the endoret. We do immediate load and On the distal implant, we were able to do a transcrestal sinus augmentation. After healing, can achieve a very interesting contour and three-dimensional soft tissue thickness that allowed us to develop two tissue zones as described by Dr. Shu. After exposing the distal implant, we place two transepithelial abutments, demultium, because we are going to make a provisional according to our wax-up. But one detail is that we need to love our provisionals and make it very polished, always without concave zones, with clear areas for the patient's hygiene and maintenance. And if we care enough for our provisionals, we can go from this initial situation on the left to this much more shaped and scalloped soft tissues contour on the right, with two zones above the transepithelial abutment, which is going to enhance the thickness of our mucosal barrier. And then, of course, finish the case in a very aesthetic way. And we can see that the bone level is going to be maintained clearly above the implant's neck level. But our first goal should be do no harm. So in order for us to achieve it, we need to be able to detect the risk factors. For example, in this patient who had a failed crown also, we have a very close nearby implant distally, which already is showing some bone loss. Also, if we analyze the CT scan, we can see that we have scarce buccal bundle bone. So it's very easy to predict that if we extract this root, it's very probable that we need to perform serious bone regeneration, or we can lose bone, both buccal and distal. The challenging results of this technique gave us enough confidence to go a little bit beyond this concept. We call the alphabet beyond this concept, and you are going to understand why. Because in this case, our strategy was to do a J-shield inspired by the socket shield technique and Ken's proximal shield technique. So instead of extracting this root, we reduced it, maintaining the root shield on the most critical areas, the buccal and the distal area. After that, we just place an immediate post-extraction implant on a flapless approach. The next step is to place an engaging transepithelial abutment, because we don't want to touch it again. And we are going to fill the gap with endoret graft and cover everything with the fibrin membrane, according to the surgical biosealing technique. And the result that we could achieve was quite interesting. We were able to maintain our anatomy, achieve very adequate volumetric contours, and on the bone level we could maintain the interproximal peaks. And we could achieve a very interesting outcome with the combination of these techniques, the J-shield and the surgical biosealing. So on this next case, which I believe it's even more challenging, we are facing again a typical crown failure, but we have adjacent implants, both mesially and distally, which present some bone loss. So our strategy was to perform a U-shield. So we are going to keep the shield where it is most needed. We want to preserve the buccal and both interproximal areas. And that's what we do. Instead of extracting the full root, we reduce it, shape a U-shield, then install the implant, fill the gap with endoret graft, cover everything with fibrin, and this is the outcome. Again, we see the engaging transepithelial abutment, and above this transepithelial abutment, which is 2 millimeters, So we have a 2 millimeter thickness mucosal barrier, but it will be even thicker vertically because we can see a dual tissue zone again that we could obtain during the provisionalization period. This case, it's also a very interesting case. Again, a typical crown failure, but with specific characteristics. We have a 2 roots premolar in direct contact with the mesial implant and are ankylosed. We should not be following this root axis because it's going to be bad from the prosthodontic point of view. And on the other hand, if we do that, we are going to end up hitting the implant. So our strategy on this case was to do a null shield. We drilled through the root, correcting the implant axis so it can be parallel with the distal implants. Then we place the implant, again fill the gap with endoret grafts, and we immediately place the transepithelial abutment on the 3 implants and build a provisional bridge that then is going to be substituted by the definitive bridge. I guess it's very interesting to observe the contour preservation. It's even more interesting to observe that we can go through the root, keep a no shield, allowing only the enough room for the bone to grow and integrate this implant. I truly believe that this O-shield concept for me is going to be the future. There is no need to lose bone on any area of the ridge. We should reduce the root to the bone level following the CEJ line, providing for 360 degrees bone preservation. I'm truly convinced that this is going to be the future PET approach. I truly hope that you have enjoyed this little lecture, and I hope you keep us tracked here on Dental XP. That's all for today. Thank you very much, and see you next time.